Gentlemen, thank you very much for joining me this afternoon. Feel free to shuffle around a bit if you're not quite in a comfy position. And I wanted to just, first of all, start by asking James a question. I'm going to ask each of them a couple of questions and then we'll talk amongst ourselves, and you feel free to join in as well. How this is going to work, I'm not entirely sure, but let's just stick with it and see how it goes. So, James, let me ask you a question first. Obviously, we've seen footage of the drones. People are talking about drones. Maybe we're going to get our Amazon packages delivered by drones at some point in the not-too-distant future. As somebody who's looked into the literature and the challenges of getting this to work as a solution for out-of-hospital cardiac arrest, is it all hype? Are we just in the peak of inflated expectations, or is this likely to happen anytime soon? What do you think?
I think, well, I really liked your graph before because I think it just tells the story with drones really well. And I think I'm really reluctant to be labeled as the drone guy because I came to this. I'm still very much on the fence with drones. And I think if you ask the public about drones and cardiac arrest, people have a lot of enthusiasm for it and they think that it's the big solution. But I suspect that if I was to ask the audience of the room, and maybe we could do that, who thinks that we're going to be using drones in the next 10 years and who doesn't? Can we do a show of hands? And yeah, and then I can answer the question and see what other people think first. So who thinks that in 10 years' time we'll have drones delivering AEDs to cardiac arrests? Okay, and who thinks that we won't? Yeah, and I guess with any new technology, it's useful and helpful to be skeptical about it. And I think if you look at that Swedish paper, which is the first example of drones being used to get AEDs to real cardiac arrests, I would encourage, even if you think you're a drone cynic, go and have a look at that paper. It's open access because you can see the problems, but what we need to do is try and address those problems and the logistics, and that's things like airspace, regulations. It's similar to the issues with pad cabinets being locked and unlocked. So we need to look at those kind of same logistical problems. So I think we will see drones being used, but I think we'll probably start seeing them in small pockets, probably on the continent. I think certainly in the UK, I imagine no one really wants to be the first ambulance service to use drones. There's risks that come with that. So I think we will see it, but I think there's going to be hesitancy and different models on the market that are competing. And so I don't think it's going to, I don't know what the timeline is here, but I say maybe 10 years, I think, as a guess.
Great, thank you. Thanks for that. You've answered questions 2 and 3, so I'm just, before we come back to that, Adam, so Scottish Ambulance Service very much leaning into research and innovation space. How do you see the research landscape in Scotland helping us address the problems of out-of-hospital cardiac arrest?
Yeah, it's an interesting one. I think, first of all, we're fairly fortunate in research and innovation that we kind of get to play about with anything. We have a bit of carte blanche, don't we? So we don't really need to say no to anything if it's badged as research or innovation to begin with, because that's what we should be doing. The research innovation team should look at all the cool, sexy stuff. So it's quite a luxurious position to be in. But I think what we have to get the right balance for in ambulance service is, if what we're hearing as a bit of a golden thread through the theme of the day is the ABC, the audit, basics, clever stuff, is we run the risk is if we push too quickly with innovation, particularly in the space of cardiac arrest where it's very high stakes, we run the risk that we might start to lose sight of some of that keep left narrative. So I think from the ambulance service perspective is we want to embrace innovation, and there are indeed some studies across the UK happening just now. Indeed, the kind of author of that keep left mindset, a chap called Charles Deacon, he's doing a study called the Cabaret study. I love the names of these studies, where it's all about medical technology. It's heads-up CPR with the Elgar device. You also get the Lucas on. You also do some impedance threshold. So this whole study that is a bit of a signal of what the future of cardiac arrest might look like is all about gadgets, and it's all about some sexy kit. However, I don't think we should, run to the things that are shiny and new without just keeping a critical eye on things. And a colleague in the ambulance service said, and it's kind of stuck in my mind, is, all that glitters isn't gold. it could look fab, and drones is maybe one of these. But I think with this group of staff that we have in the ambulance service, I don't think we're going to run too quickly. I think patients first. Let's get to these patients, and if there's some wins in there, then we'll keep a critical eye on things.
Thanks, Adam. And just because time was a little shorter than I was expecting, let Stuart answer as well. Now, I know, Stuart, you've got your ear to the ground from an intensivist perspective on what new techs and techniques, and there are always new techs and techniques, might be on the horizon for cardiac arrest. What do you see as you look into the horizon?
So my particular interest is in those patients whose cardiac arrest is refractory to the initial resuscitation attempts, refractory to the ALS, and particularly those patients who have an initial shockable rhythm. Because I think a proportion of those, probably a big proportion of those, are patients who have something reversible going on, but at the moment we just can't maintain sufficient perfusion to get them to the point we can reverse that problem. And there's a few things going on internationally and including in the UK. They're looking to try and address that. And I think there's two broad avenues that people are looking at. There's using, it's not even innovation, it's more repurposing existing technology and techniques. So using these existing techniques to optimize what we're currently doing. So to ensure that the CPR we're doing is adequate, to ensure that the adrenaline we're giving is achieving what we think it's achieving. And some groups are looking at or introducing echocardiography, particularly transesophageal echo, to look at the effect of compressions. That's got the advantage over the transthoracic echo that many of you will be familiar with, in that it can stay in situ. So you can watch the effect of the mechanical CPR. You can see what impact it's having in terms of compression and flow. The other thing that's being done, like East Anglia have really been pioneering this in the UK, is insertion of arterial cannula into the patient's femoral artery. It's something that's used in every intensive care unit, every high dependency in the country, and it allows beat-to-beat monitoring of blood pressure. And in CPR, you can monitor what the pressure is, you can see effectiveness of CPR, you can see the effect of the adrenaline, and ensure that there is sufficient pressure within the circulation to get coronary flow and ultimately ROSC. So there's potential scope for innovation and development there. And then the other avenue, I think, is around doing other things to optimise perfusion, to try and get those coronaries with blood flow in them to achieve ROSC. And there's a couple of things being looked at. The one that's probably gathering the most evidence base at the moment is the use of ECMO as an adjunct to CPR, so eCPR. And there's a few randomised control trials now being published. One of them showed spectacular results with 40% of patients surviving neurologically intact who were in refractory cardiac arrest. The others have been slightly less convincing as a headline figure, but actually, when you dig down into it, it does seem there's a very strong signal that the right patients in the right system will get great benefit from eCPR. And I think from a Scottish perspective, we've spent a bit of time with Gareth and his team looking at the numbers, and there are patients out there in refractory VT-VF who we cannot rescue at the moment. And it may well be if we can get the system right, then we can look at bringing in these kind of innovations, bringing eCPR to the Scottish population. It's not easy. If it was easy, I think we'd already be doing it. But I think it's a challenge that there's many people in the system who are up to. And then the final thing that's maybe a halfway house that's out there is the use of Reboa, which is more commonly described in trauma. It's an insertion of a balloon into the aorta to stop flow down the aorta. And that the theory is that by doing that, you can raise the pressure within the aortic root and improve flow into the coronary arteries. Same principle, but it's just slightly less involved than ECMO, particularly in the downstream phase. And again, East Anglia are currently doing a feasibility study in that in the pre-hospital environment. So lots and lots of things going on. None of them are logistically straightforward. None of them especially cheap, but all of them, I think, hold a great deal of promise and real potential there to take that group that at the moment we just cannot rescue and turn them into survivors.
That's really interesting. I was quite struck there, Stuart, by the first couple of things you mentioned are techniques that are relatively commonly used in intensive care, transesophageal echo, invasive arterial monitoring and so on. And essentially, rather than inventing a new thing, you're taking an existing thing and putting it into a new context to give benefit, which is innovation. And to your point, Adam, is often overlooked. You know, it doesn't have to necessarily be glittery and shiny to be gold, I think. So here's a question for anybody who wants to answer it then. It sounds like there are things out there, and there are other things, obviously, that we haven't touched on, other technological advances that could be used to help us in this quest to improve survival. How do we go about appropriating this? How do we make this work in the Scottish context?
So if I could maybe throw a couple of thoughts out there, I'm thoughtful that there's a few colleagues here. Our chair of the board of the Ambulance Service does a lot of work with the Chief Scientist's Office and supporting national innovation. And there are some success stories from across Scotland in other areas. There's some kind of digital innovations around diabetes, around maternal and fetal care, around digital dermatology. And so those success stories, I think, can offer a bit of a blueprint for cardiac arrest, where you've probably got to look across the whole system. And I was probably reflecting, because I don't know about other clinicians in the room. I'm a nurse, and I know there's lots of paramedics. Is some of the kind of roboa high-end stuff sounds a bit intimidating and sounds a bit, you know, not within our grasp. So I think as an approach is if what the kind of last 10 years of cardiac arrest has taught us is to look across the whole system. I think it's probably, if we can map that same innovation mindset over that, is maybe it won't just be a device, maybe it won't just be a widget that drastically increases survival. It's probably looking for spaces where innovation can slot in, right at the patient's bedside, in their own home, where the majority of arrests are, all the way up to secondary care. So I think that seems to be a useful model that's working in Scotland, and there's a good infrastructure of innovation test beds and the Chief Scientist's Office that are supportive.
And I think there's something there maybe about how we work with industry as well, because it's really easy to be skeptical about working with industry, particularly in a research setting. But I'm going to use a drone example again, sorry. But you know, there's 3 or 4 companies out there developing drones that they think could deliver AEDs in the future, and they all have problems. And I think anyone who's been to lots of cardiac arrests, you know, people in this room, will look quite skeptically at some of these devices and say, oh, I can see the problems at X, Y, and Z straight away with that. So I think one of the things we need to do is recognizing that some of these new technologies are still not ready to go yet, but trying to be involved in steering and feeding back and helping design those things. So we probably need to think about how we best work with industry to kind of give them our wish list almost. Yeah.
I think, if I can pick up on that, James, is something that we found working with James in the simulation study was that something that maybe we didn't think of that would be as important was kind of taking the public on that journey with us. In that if they hear the blue lights and the sirens, you know, the paramedic arrives, they do some stuff, they take them to hospital. If in this imagined future, which is our favourite phrase, we talk about an imagined future with drones, is James and I had to spend a bit of time debriefing these volunteers, these members of the public, after they'd interacted with the drone, because for them outside, even though they knew what they were going into, some of them found it a bit distressing, and them looking up, seeing a drone in the sky, which was 50 metres up, and then having me on the phone for half of them, some of them were quite, I don't know if I'd say emotional, but James and I had to invest a bit of time at the end to say, how did you feel? And said, well, this felt very real, and I don't know how comfortable I would feel trying to do that if this was my loved one or a spouse. So if we think about that kind of demographic of traditional cardiac arrest patients, I don't know how comfortable the public would feel if it's somebody who's slightly older and we say to them, well, if you just go out your house, leave your husband or wife very briefly, or if there's potentially a third-party person there, if you can just go and look out in the sky for a drone that's noisy, and it's going to have sirens, and it's going to say, stand clear, stand clear. So all that kind of learning from Claeson's study in Sweden is helpful for us. So although we can get the drone there might be a really good defib. We've got our process very slick. Our call handlers are getting the defib. Everything's done. All the regulations are in place. If the final part of that is a member of the public who just can't do that final part, then no matter what the innovation is, we're not going to change the dial. We're not going to move the dial in the right place. So I think the public have to come along with us on that.
And I think we need to use the innovations try and fix those problems we know are there in the chain of survival, whether that's you know, arrests happening in people's homes and not near pads, rather than using the innovations for the sake of using the innovations, really.
Oh, that's great. Lots of interesting stuff there. So if I've heard you correctly, think about the unintended consequences and the difficulties maybe in interfacing the innovation with the problem. And I think I just heard you say at the end there, James, let's look for solutions to our problems, not try and find problems for solutions that people bring us to test, which sounds great, a great idea to me. Got one or two final comments to make, but just before, as we wrap up, were there any questions from the audience? We can probably take a couple of questions. Yes, please. I'm going to get you to say that one more time, just so that the people on the stream can hear you, because thank you.
I was just really going to ask this question to Stuart about in-hospital situations, because he spoke there about some like having arterial line monitoring and stuff. How important do you see the role of critical care when it comes to a cardiac arrest team in the hospital being?
So I suppose it's not so much about one specialty, it's about the right people delivering the right interventions at the right time. And I think that whether that's in the hospital or in the pre-hospital environment, there are a variety of people who can do that. I think one of the big challenges if we hopefully move towards a more innovative approach to these cardiac arrests is how we potentially take things that have been traditionally the role of one very specific group and maybe put them into the hands of another group who are better placed or have a wider skill set that's more suited to operating in that environment, for example. So I think part of the innovation of bringing in these technologies is trying to break down the barriers between different professional groups, different specialties, and just making sure that the system is set up so that the right person's there to deliver them and they are appropriately trained and governed to do so.
That's great. Thank you. We've got one more question. Just there at the back, is that Debbie, I think?
Hi, we've spoken a wee bit today about people being able to access treatments. I just wonder if you think that this innovation could actually create another set of inequalities in Scottish healthcare. That would certainly be a concern of mine. The stuff sounds brilliant, but only if you can access it.
It does. It's a really useful question, Debbie, and I guess there's potentially some remedies to that almost built into the kind of infrastructure, if you like, whereby often now funders or bodies on behalf of the government, say for example like the Chief Scientist's Office or say the NIHR in England, is often the staff and clinicians like us who want to try and pursue these innovations. We often have to be able to clearly demonstrate how we're either kind of acknowledging the potential of creating bias or inequalities or just that we're not even addressing them. So we do run that risk, but I suspect that inequalities has probably crept up on everybody's radar over the last 10 to 15 years, and it now feels like it's become front and center alongside things like patient and public involvement that used to be a bit variable, now is kind of a core pillar of if anybody wants to do some new work. So I'd like to think that it shouldn't happen. It probably still does in the real world, which is why the health inequalities, landscape hasn't probably shifted large amounts. But yeah, it's definitely on, I think, our radars as
a good example of that in some of the simulation work we've done. We've seen a kind of small signal that people for whom English is not their primary language, if English is a second language, maybe struggle to follow some of the instructions that call handlers would give on the phone. And so if we're implementing these new technologies around bystanders, whether that's pads, whether that's drones, there's a key thing in the usability testing and making sure that we test things for the people who are going to use them. And it's really interesting. If you look at AEDs and the regulatory approval process they have to go through, certainly in the US, they all need to go through usability testing. But normally they get tested with people who have previously been trained in BLS and AED, who may be medical professionals. And these are the AEDs that we're putting in boxes and expecting people with no training to use. So I think there's quite a lot in the regulation and the usability testing about making sure we make and use products for the people who are going to use them so that we don't encounter these inequalities further down the line.
Great. Thank you very much. You've just set me up nicely to make the final comment I wanted to make, which is all innovation doesn't have to be about tech and digital. Some innovation is about how we research into how we reduce those inequalities. Work like Raid's PhD work from earlier, very interesting investigation into exactly what you're describing, Debbie. Why is it that some people seem to get such a worse deal than everybody else? And when we scratch away at what the reasons might be, they're not the reasons that we first thought. So what do we do with that? Research and innovation can be about the psychology of interactions during cardiac arrest. It can be about the sociology of that, about the communication around that, not necessarily all about gadgets, although they're very fun. So, thank you very much. Thank you very much to you three. Feel free to skip.